Now we'll be starting with chapter 34th of Apurba Sastry Essentials of Microbiology, which is viral hemorrhagic fever. In this video, we will be covering the introduction and dengue part, while the subsequent parts will be covered in the next videos. Viral hemorrhagic fever. Viral hemorrhagic fevers are defined as a group of illnesses caused by different families of viruses that cause vascular damage that results in symptomatic bleeding hemorrhage. VHFs are caused by viruses of three distinct groups. Arboviruses transmitted by arthropod vectors, examples include dengue, yellow fever virus, filoviruses such as Ebola and Marburg virus, rodent-borne virus such as hantavirus and arenavirus. Note: rarely bacterial infections such as scrub typhus and leptospirosis can also cause hemorrhagic fever. General properties. Hemorrhagic fever viruses share a number of features. They are all enveloped RNA viruses. Distribution: they are geographically restricted to areas where their host species live. Example: Ebola virus in Africa. Severity: some types of VHF, example dengue, are relatively mild, whereas many of these, example Ebola, are severe and life-threatening. Reservoir: their survival is dependent on an animal or insect vector which serves as a natural reservoir. Humans are not the natural reservoir. They can be occasionally transmitted to humans when come in contact with excretions of infected animals or arthropods. In some insects, once the virus infects humans, person to person transmission can occur when an uninfected person comes in contact with the bodily fluids, example Ebola, or by the bite of an arthropod vector, example dengue. Symptoms: VHF presents with fatigue, fever, weakness and dizziness, and muscle aches. Patients with more severe infections show bleeding under the skin, internal organs, or even from external body orifices such as the mouth, eyes, or ears. Some patients develop severe diarrhea that may also be bloody, and severely ill patients present with shock, delirium, seizure, kidney failure, and coma that often ends in death. Epidemiological pattern: VHF cases occur in either sporadically or as seasonal outbreaks, example dengue in India, or sometimes as explosive epidemics, example Ebola in Africa to 2014. The occurrence of outbreaks cannot be easily predicted. Treatment: with a few noteworthy exceptions, ribavirin or Lassa fever, there is no definitive treatment available for VHFs. Cases can only be managed by symptomatic treatment. Vaccine: no vaccines available for VHF with the exceptions of yellow fever and dengue. Arboviral infections. Arboviruses, arthropod-borne virus, are a diverse group of RNA viruses that are transmitted by blood-sucking arthropods, insect vectors, from one vertebrate host to another. Viruses that multiply inside the insect and establish a lifelong harmless infection in them. Thus, the viruses which are just mechanically transmitted by insects are not included in this group. Introduction. Arbovirus are taxonomically diverse, belong to 5 different families. Still, the name Arbovirus is internationally accepted as the members under this group are comparable in many ecological and epidemiological factors such as geographical distribution, mode of transmission, type of insect vector, clinical features, and their control measures. Classification. Members of Arbovirus are RNA viruses belonging to 5 different families: Togaviridae, Flaviviridae, Buenaviridae, Rioviridae, and Rhabdoviridae. As we can see in this table, the family Togaviridae causes disease like chikungunya, O Nyong Nyong virus, Mario virus, Ross River virus, Sandwich virus, Semiliki forest virus, Eastern equine encephalitis virus, Western equine encephalitis virus, Venezuelan equine encephalitis virus. Family Flaviviridae causes diseases like Japanese bee encephalitis virus, St. Louis encephalitis virus, West Nile encephalitis virus, Murray Valley encephalitis virus, Rokio virus, Russian spring summer encephalitis virus, Powassan virus, looping ill virus, dengue virus, yellow fever virus, Connoisseur forest disease virus, OMSK hemorrhagic fever virus, and Zika virus. Family Buenaviridae causes disease like California encephalitis virus, Oro pouch virus, sandfly fever virus, Rift Valley fever virus, Cambrian Congo hemorrhagic fever virus, Ganjum virus, severe fever with thrombocytopenia, and syndrome virus. Family Rioviridae, Colorado tick fever virus, Orongo virus, Camidivo virus. Family Rhabdoviridae, vesicular stomatitis virus, Chandipura virus. Okay. So, continuing, individual viruses under each family are named after various features such as clinical feature. For example, yellow fever is named after its main clinical feature, jaundice. Okay, place of discovery, for example, Connoisseur forest disease virus. Vector needed for transmission, for example, sandfly fever virus. Peak season, for example, Russian spring summer encephalitis virus. Multiple features. Japanese encephalitis virus is named after the place of discovery and clinical feature. Clinical manifestations. Arboviruses may also be arbitrarily divided based on the pattern of clinical syndromes they produce. Fever and or rash and or arthralgia group. Encephalitis group. Hemorrhagic fever group. However, some of them may be associated with more than one clinical syndromes, example dengue virus. Epidemiology. Zoonotic. Several hundred arboviruses exist in the world and are all believed to be endemic in animals. However, only about 100 are human pathogens. Transmission cycle. Arboviruses are maintained in the nature between animals and the insect vectors. Humans are the accidental host and do not play a role in the maintenance or transmission cycle of the virus except for urban yellow fever and dengue. Arthropod vector. Most arboviruses are transmitted by mosquitoes, Aedes, Culex, or Anopheles, followed by ticks and rarely sandfly and other insects. Climatic variation. Arboviruses are more prevalent in the tropics than temperate climate due to abundance of appropriate animals and arthropods in the former. Geographical distribution. Our viruses vary greatly in their geographical distribution, which in turn depends on the various factors such as climatic condition and presence of vector. Viruses that are highly endemic in one place may not be found in other areas. Yellow fever is highly endemic to West Africa but not found at all in India in spite of its vector Aedes aegypti being widely distributed in India. Encephalitic arbovirus, Eastern, Western, and Venezuelan equine encephalitis viruses are prevalent in North America, whereas in India, Japanese encephalitis virus is the most common arbovirus causing encephalitis. Arboviruses found in India. Over 40 arboviruses have been detected in India, which are highly endemic. Of which three are highly endemic and produce several outbreaks every year. Common arboviruses prevalent in India include hemorrhagic fever group, dengue and Carnosaur forest disease virus, and fever with arthralgia group chikungunya virus, encephalitis group, and Japanese bee encephalitis and West Nile encephalitis virus. Okay, the rare ones are Sindwis, Kimbrian Congo hemorrhagic fever, Ganjam, Vellore, Chandipura, Bhanja, Ombre, Satuperi, Chittur, Minnal, Venkatapuram, Dhori, Kaisodi, and sandfly fever viruses are among the rare arboviruses found in India with limited geographical distribution. Arboviruses which are prevalent in other parts of the world but not in India are not discussed but only enlisted in table 34.15 except for Zika virus and yellow fever virus. Zika virus. It causes fever, arthralgia, and congenital infection has recently caused explosive epidemic in Brazil in 2015. Discussed later. Yellow fever virus is an endemic West Africa and Central South America. It infects liver, causes hepatitis and jaundice, and also hemorrhagic fever. Because of its vaccination and importance for international travelers, it has been discussed in this book. Lab diagnosis: arboviral infections. Antibody detection: ELISA, IgM, and IgG specific and immunochromatographic test (ICT). Virus isolation: mosquito inoculation. Adult or larval stages of toxorhynchitis, best, Aedes aegypti, and Aedes albopicus. Mosquito cell lines such as C6, 36, and AP61. Mammalian cell lines such as Vero and LLC-MK2 cell lines, least sensitive. Suckling mice, intracerebral inoculation. Detection of an antigen in blood. Example, dengue virus specific NS1 non-structured antigen 1 by ELISA and ECT, and fixed tissues by immunochemistry or direct IF. Molecular method RT-PCR and real-time PCR. So now we start with dengue. Dengue virus DENB is the most common arbovirus found in India. It belongs to family Flaviviridae. It is an enveloped virus containing ssRNA. It is named after the Swahili word dinga, meaning fastidious or careful, which would describe the gait of the person suffering from the bone pain or dengue fever. It has four serotypes, DEN 1 to DEN 4. Recently, the fifth serotype, DEN 5, was discovered in 2013 from Bangkok. Vector. Aedes aegypti is the principal vector, followed by Aedes albopicus, that bite during the daytime. Aedes aegypti is the nervous feeder, so it bites repeatedly to more than one person to complete a blood meal, and resides in domestic places, hence it is the most efficient vector. Aedes albopicus is found in peripheral urban areas. It is an aggressive and concordant feeder, that is, can complete its blood meal in one go, hence it is less efficient in transmission. Aedes become infective only when it feeds on viremic patients, generally from the day before to the end of February period, that is 5 days. Extrinsic incubation period of 8 to 10 days is needed before Aedes to become infective. However, once infective, it remains infective for life. Aedes and can pass the dengue virus to its offspring by transovarial transmission. Transmission cycle: man and Aedes are the principal reservoirs. Transmission cycle of four serotypes do not involve other animals. In contrast, the fifth serotype follows celiovatic cycle. Alright. Now the pathogenesis. Primary dengue infection occurs when a person is infected with dengue virus for the first time with any one serotype. Months to years later, a more severe form of dengue illness may appear, called secondary dengue infection, due to infection with another second serotype, which is different from the first serotype causing primary infection. Antibody response against dengue virus. Infection with dengue virus induces the production of both neutralizing and non-neutralizing antibodies. The neutralizing antibodies are protective in nature. Such antibodies are produced against the infective serotype which lasts lifelong, as well as against the serotype which lasts for some time. Hence, protection to infective serotype stays lifelong, but cross-protection to other serotype diminishes over a few months. The non-neutralizing antibodies last lifelong and are heterotypic in nature, that is, they are produced against other serotypes but not against the infective serotype. Such antibodies produced following the first serotype infection can bind to a second serotype during the secondary dengue infection, but instead of neutralizing the second serotype, it protects it from the host immune system by inhibiting the bystander B cell activation against the second serotype. ADE. The above phenomena is called antibody dependent enhancement. Non neutralizing antibodies promote recruitment of mononuclear cells followed by release of cytokines, which explains the reason behind the severity of secondary dengue infection. Among all the serotypes combination, ADE is remarkably observed when serotype 1 infection is followed by serotype 2, which also claims to be the most severe form of dengue infection. Clinical classification. Traditional 1997 WHO classification. This classification divides dengue into three clinical stages. Dengue fever, TF. It is characterized by abrupt onset of high fever, also called biphasic fever, breakbone fever, or saddleback fever. Maculopapular rashes over chest and upper limbs, severe frontal headache, muscle and joint pain, lymphadenopathy, retroorbital pain, loss of appetite, nausea, and vomiting. Dengue hemorrhagic fever, DHF. It is characterized by high-grade continuous fever, hepatomegaly, thrombocytopenia, platelet count less than 1 lakh per mmq, raised hematocrit, PCV by 20%, evidence of hemorrhages which can be detected by positive tourniquet test, more than 20 petechial spots per square inch in cubital fossa. A spontaneous bleeding from skin, nose, mouth, and gums. Dengue shock syndrome DSS. Here, all the above criteria of DHF are present, and in addition, manifestation of shock are present, such as rapid and weak pulse, narrow pulse pressure less than 20 mm Hg or hypotension, presence of cold and clammy skin, restlessness. 2009 WHO classification. This is the most recently described classification by WHO, which grades dengue into two stages based on the severity of infection. That we'll see in the figure as well. Dengue with or without warning signs and severe dengue. Alright. Factors determining the outcome. Infective serotype type is apparently more dangerous than other serotype. Okay, type 2. Sequence of infection: serotype 1 followed by serotype 2 seems to be more dangerous and can develop into dengue hemorrhagic fever DHF and dengue shock syndrome DSS more often than others. Though all age groups are affected equally, children less than 12 years are more prone to develop DHF and DSS. Dengue during pregnancy. Perinatal transmission of dengue fever can occur. Peripartum maternal infection may lead to symptomatic infection in the newborn, who may present with fever, thrombocytopenia, ascites or pleural effusions, typically during the first week of life. The geographical distribution. Global scenario: dengue is epidemic in more than 100 countries with 2.5 billion people at risk. Tropical countries of Southeast Asia and Western Pacific are at the highest risk. About 50 million of dengue cases occur every year worldwide, out of which 5 lakh cases, mostly children, proceed to DHA. So now in the figure we see the dengue case classification based on the severity by WHO 2009. So in the first Venn diagram we see the dengue plus warning signs, with or without or with warning signs, and the severe dengue we see the severe plasma leakage, severe hemorrhage, and severe organ impairment. So the criteria for dengue plus minus warning signs: probable dengue, live in or travel to dengue endemic area, fever and two of the following criteria: nausea, vomiting, rash, aches and pains, tourniquet test positive, leukopenia, any warning sign. Laboratory confirmed dengue. It is important when no sign of plasma leakage. Warning signs: abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement by 2 cm, more than 2 centimeter, laboratory increases in the HCT concurrent with rapid decrease in platelet count, requires strict observation and medical intervention. Criteria for safe dengue: severe dengue, severe plasma leakage leading to shock, dengue shock syndrome, fluid accumulation with respiratory distress, severe bleeding as evaluated by clinician causing hemodynamic instability that may require blood transfusion. Severe organ involvement: liver, AST or ALT more than 1000 international units per ml, CNS, impaired consciousness, heart and other organs. Okay, so now we come to the situation in India. Disease is prevalent throughout India in most of the urban cities or towns, affecting more than 31 states or union territories. Last decade, every year more than 1 lakh cases of dengue with more than 200 deaths occur in India. Maximum cases have been reported in descending order from West Bengal, Tamil Nadu, Punjab, Kerala, Delhi, Karnataka, and Maharashtra. In 2021, more than 1.3 lakh cases were reported with more than 100 deaths. A maximum were from Uttar Pradesh and Punjab. All four dengue serotypes have been isolated from India. Serotype prevalence varies between seasons and places, but DEN 1 and DEN 2 are widespread. DEN 5 has not been reported yet. Lab diagnosis. The outline of lab diagnosis of dengue is similar to that of other arboviruses as described earlier. NS1 antigen detection. ELISA and ICT formats are available for detecting NS1 antigen in the serum. They gain the recent popularity because of early detection of the infection. NS1 antigen becomes detectable from day 1 of fever and remains positive up to 18 days, up to 7 days for the latest edition. Highly specific, it differentiates between flaviviruses. It can also be specific to different dengue serotypes. Antibody detection. In primary infection, antibody response is slow and of low titer. IgM appears first and after 5 days of fever and disappears within 90 days. IgG is detectable at low titer in 14 to 21 days of illness and then it slowly increases. In secondary infection, IgG antibody titers rise rapidly. IgG is often cross-reactive with many flaviviruses and may give false positive results after recent infection or vaccination with yellow fever virus or JE. In contrast, IgM titer is significantly low and may be undetectable. In past infection, low levels of IgG remain detectable for over 60 years in the absence of symptoms is a useful indicator of past infection. MAC ELISA, IgM antibody capture ELISA. This is the recommended serological testing in India. Kits are supplied by NIV Pune. It is principle. It is a double sandwich ELISA which captures human IgM antibodies on a microtiter plate using anti-human IgM antibody followed by the addition of dengue virus 4 serotype specific envelope protein antigens. This step makes the test specific. There is a signal enhancement due to the use of evident biotin complex ABC, which makes the test more sensitive. Cross-reactivity with other flaviviruses is the limitation of this test. Neutralization tests such as plague reduction test and microneutralization test are available. They are cumbersome but are more specific serologic tests. Rapid diagnostic test RDT for dengue. Rapid diagnostic test example ICT for dengue, IgM antibodies or NS1 antigen are available but have poor sensitivity and specificity. Government of India had passed an order in 2016 that a positive RDT for dengue, NS1 or IgM should be considered as probable diagnosis must be confirmed by ELISA. The virus isolation. Dengue virus can be detected in blood from -1 to +5 days of onset of symptoms. Virus isolation can be done by inoculation into the mosquito cell line such as C636 and AP61 or in mouse. It is available for research purpose and in different centers. Molecular method. Detection of specific genes of viral RNA 3-UTR region by real-time RT-PCR. It is the most sensitive 80 to 90% and specific assay 95% can be used for detection of serotypes and quantification of viral load in blood. Viral RNA can be detected in blood from -1 to +5 days of onset of symptoms. A negative PCR result is interpreted as indeterminate, which has also to be sent for serological confirmation after the fifth day of illness. Genotype detection. Each serotype of dengue virus comprises of several genotypes which can be detected by molecular typing. A total of 13 genotypes have been detected so far. 3 for dengue 1, 2 for dengue 2, 4 for dengue 3 and dengue 4 serotypes respectively. Treatment. There is no specific antiviral therapy. Treatment is symptomatic and supportive such as replacement of plasma losses, correction of electrolyte and metabolic disturbances, platelet transfusion if needed. Prevention. Vaccine development for dengue has been a challenge and it should be effective against all four serotypes. After so many trials, recently a vaccine has been licensed for human use since 2015. Several more vaccine trials for dengue are ongoing, including two Indian trials, a live attenuated vaccine Tetravax DV and a tetravalent dengue vaccine subunit vaccine DSV4. Mosquito control measures as discussed for malaria. Dengue vaccine CID-TTV. This vaccine has been licensed for human use since 2015. It is a chimeric yellow fever dengue live attenuated tetravalent dengue vaccine CYD-TT, commercially available as Dengvaxia, developed by Sanofi Pasteur. It uses live attenuated yellow fever 17D virus as vaccine vector, in which the target cells of all four dengue serotypes are integrated by recombinant technique. Age. It is indicated for 9. uh, WHO recommended Dengvaxia for person aged 9 to 45 years with confirmed previous dengue infection. If this vaccine is given to people who have not been previously infected with dengue, then they may be at higher risk of developing severe dengue following subsequent DNB infection. Schedule 3 injections of 0.5 ml administered subcutaneously at 6 months interval. It is available as lyophilized form reconstituted with normal saline. Contraindications. Allergic reactions to vaccine, immunodeficient individuals, example HIV, pregnant and breastfeeding women. Efficacy against hospitalized dengue illness was found to be around 80%. WHO recommends to start this vaccine in high burden countries. Seroprevalence more than 70%. The WHO also recommends dengue vaccine to be used only in people previously infected with dengue. If this vaccine is given to people who have not been previously infected with dengue, then they may at be higher risk of developing severe dengue following subsequent DNV infection. Currently, the vaccine is approved in Mexico, Philippines, Brazil, Indonesia, Thailand, and Singapore. In India, it is not available yet because of safety issues. Okay, so this completes our part 1 of the chapter, and we'll continue the part 2 in the other video. Okay, thanks for watching. Like, share, subscribe.